Fantastic. I am Jennifer Schrack, for those of you who don't know me. I'm trying to get this. Got it. Okay. I have a few quick announcements before I introduce our speakers for today. So first, I just want to draw everybody's attention to the walk to end Alzheimer's. So we have a lot of complementary aging centers sponsoring this year's event. COA is just one of them. We would be thrilled if you would join in the efforts, either by donating or coming to walk. I know a few of us at least are planning to actually go and walk. So if you're interested and in the Hunt Valley area on October 28th, please join us. It should be a great event. The next thing in our announcements. So today, this is our seminar for today, which I'll introduce our speaker in just a minute. But we do also have our November 6th speaker lined up and confirmed. It's going to be Catherine Ornstein from the School of Nursing. She's the director for the Center for Equity in Aging at School of Nursing. And her talk will be Home, but Homebound, Aging in the Community with Serious Illness. So we hope that you guys will be able to join us for that talk as well. Okay. So today I am very happy to introduce two of Hopkins' finest to talk about some of the most exciting research results that came out this summer. We have Dr. Frank Lin and Dr. Joe Korish. I think many of you know them, and so I promised I would keep this short and sweet. So Frank is the director of the Cochlear Center for Hearing and Public Health. He's a professor of otolaryngology, and he has both his MD and PhD from Hopkins. Dr. Korish is the George W. Comstock Professor of Epidemiology. He's core faculty of the Welch Center, and he also has his MD and PhD from Johns Hopkins. So they have a lot in common, and they are here to talk about the ACHIEVE randomized trial. As I said, I think these are some of the more exciting research results to come out of Hopkins this summer. So please take it away.
Good afternoon, folks. And then Joe and I are going to tag team throughout this presentation today. So I'll be going, and then Joe will be going, and go back and forth. But a couple of quick words first. I just learned Jennifer Schrack was from a professor, I think, a few days ago. So I think a word of congratulations in order. And the second thing is really interesting is it's oddly fitting that we're giving this talk here today, because Joe probably remembers this whole ACHIEVE saga, which we'll hear about in upcoming slides. We'll hear about the actual results, though. It began actually, no joke, 10 years and 7 months ago today in this room, because I was giving a Welch Center talk at that time around some work around hearing loss and healthy aging cognition. Joe was sitting right there, and no, you're in the front row. Yeah, but you're sort of staring at me. I remember this. Yeah, and then so I never really met Joe before, but we sort of hit it off, and then. Everything you're seeing in the next 45 minutes is a direct result of Joe just attending my talk and saying, hey, Frank, we should talk afterwards. And from there, that's where this whole 10-year process with the ACHIEVE trial began, because we had basically a 2-year clinical trial planning grant. At that point, it was already under review, but then we had to resubmit, ended up partnering with Joe, and the rest is history per se. So only fitting again here, it's one of the hallmarks of Hopkins that really just foster good collaborations. I think part of it is just literally being in person sometimes and incidentally meeting people. Like that never would have happened online, I don't think.
Have you ever heard
All right.
Frank talk?
So the first thing about this presentation had to begin with a word of thanks. So Joe and I are the co-PIs of the ACHIEVE trial, or ACHIEVE series of studies that finally represents 8 different universities across the country, over 30 different investigators, over 50 different staff across a whole bunch of sites across the sites. So we are just the representatives, I would say, of this study effort. And presenting to you today on behalf of sort of everyone here. All right, so what you guys are gonna hear today, it's gonna be a breakdown. Joe and I are tag team. This is the same presentation we gave when we revealed the results this summer at the Alzheimer's Association meeting in Amsterdam. I'll give you some brief background on hearing loss and dementia, so we're on the same page. Joe then will go over a much longer portion around the study designs, the methods, and the ACHIEVE cohort characteristics. From there, I'll go over sort of the evidence for the impact of hearing intervention on some proximal measures and actually the primary and secondary cognitive outcomes. Joe will then touch on some of the exploratory analyses on the other exploratory outcomes. And finally, we'll finish a brief summary and conclusion. This whole talk should be about 40 to 45 minutes. That's it, hopefully. So hopefully enough time for questions and answers afterwards and discussion. All right. So background, what we studied and why. Many of you may have seen this figure. So the Lancet Commission on Dementia in 2017 and 2020 did a major meta-analysis of all the essentially existing known modifiable or say potentially modifiable risk factors for dementia. And in 2017, again, 2020, they identified hearing loss in mid and late life as arguably being the single largest potentially modifiable risk factor in terms of population attributable fractional risk, accounting for about 8% of all potential dementia cases. And importantly, we say potentially modifiable because some of the hypothesized mechanisms that link hearing loss and dementia are potentially modifiable. So one of the first mechanisms, the idea of cognitive load, also termed the information degradation hypothesis. General notion there is if the ear has been damaged for progressive aging and it's constantly sending a much more garbled signal to the brain's constantly having to reallocate, rededicate more resources to dealing with the decoding of that garbled sound, and then comes at expense of our other thinking and memory systems. So it's not so much there that hearing loss causes dementia, but it can lead to earlier phenotypic exposure of dementia, because that cognitive load, that cognitive reserve, otherwise could have buffered against known dementia pathology, amyloid, tau pathology, neurofibrillary tangles, microvascular disease, would otherwise be expended on dealing with hearing all the time, right? And there's actually very nice both sort of functional MRI evidence as well as other psychological evidence to support this notion of a load on the brain that is always there. Don't forget, hearing is not something you turn on or off. So that load of processing degrade auditory sound is likely always there. A second mechanism, which sounds similar, but is actually very, very different, gets at the sensory deprivation hypothesis, is the idea that with auditory deprivation, a degraded auditory signal sending to the basically lateral temporal lobes, is that you actually have loss of stability and increased structural atrophy there over time. And you see this with animal models again, as well as longitudinal MRI studies of humans. So very much ideas of auditory deprivation leading to loss of structural integrity of parts of the lateral temporal lobe, but which subserves auditory functioning, but also subserves other areas of brain function as well. So that's the second idea. This one's a little different though, because this one suggests that hearing loss, in fact, could quote unquote damage the brain, not just lead to like a load on the system. Third mechanism is probably the most intuitive. It's that for some people, in some way, shape, or form, hearing loss and not be able to communicate well can contribute to social isolation and loneliness. And in turn now, we've long known that participation in cognitively stimulating activities, remaining socially and intellectually stimulated, is important for maintenance of cognitive function in the long term. All right, so the reason why we mention these mechanisms again is because if you believe these mechanisms may be in play based on the existing literature, it does suggest plausibly that hearing intervention, basically something is using a hearing aid and using it well, it could potentially modify these pathways and hence reduce cognitive decline, potentially reduce the risk of dementia. Namely, with a hearing intervention, namely a hearing aid, we certainly hope by providing clear auditory sound to the brain, you can reduce cognitive load. We certainly hope providing increased auditory neural brain stimulation. And obviously, the whole reason we treat hearing is to hopefully improve social engagement and communication. And then this finally brings up the idea then of hearing being a potentially modifiable mid to late life risk factor for cognitive decline dementia. This is important because hearing loss is highly prevalent. There are existing rehabilitative interventions that come at absolutely zero risk, right? And that are widely underutilized at present. So it's a really, really appealing public health target from that point of view because it's common, it's treatable, underutilized, and the treatments come at essentially, zero risk. But an issue though is fundamentally this question though of whether we treat hearing loss and this could reduce cognitive decline. Well, it really remained unknown, right? Because you can't answer that from observational studies. So a lot of observational studies today that Joe and I have done, others have done, you can actually look at hearing aid use as a variable in those analyses, and more often than not, on average, self-reported hearing aid use is associated with essentially better cognitive function. But you can't attribute much to that though, right? Because you can imagine people who use hearing aids versus those who don't are more likely to be healthier, wealthier, better educated, a whole range of factors. So any attribution to hearing aid use and better outcomes is tough, right? But studies have suggested that. So a big meta-analysis published in JAMA Neurology just done a few months ago suggested as, in their models, and they try to adjust for stuff, they do propensity score analyses. It showed on average that there was reduced hazard of long-term cognitive impairment or cognitive decline. The key thing, though, you can imagine the only way to definitively answer this is with the randomized controlled trial. All right. So that's exactly what the ACHIEVE trial is. Fundamentally, it's a very, very conceptually simple study. It's fundamentally, if you treat hearing loss and you treat it well in older adults, can we in fact reduce cognitive decline, global cognitive change over a 3-year period, right? So the ACHIEVE trial is called the Aging Cognitive Health Evaluation Elder Study. The main focus, the primary outcomes are focused on cognition. And the secondary outcomes, or actually the exploratory outcomes, focus on brain MRI structure, mental health well-being, physical function, healthcare use. There are a lot of people in this room who are involved in the ACHIEVE study in some way, shape, or form. Today, we're going to focus mainly on presenting the main cognitive results. We'll also share some of the early exploratory analyses looking at some of the social function measures. And then we have time to the end. We have one pocket slide looking at some of the brain MRI data that's just coming out now as well. You're up, Joe.
All right. Well, thank you, Frank. So it's a pleasure to be with you here today, and it's a great packed room. A couple of reflections. I think meeting Frank was one of the great pleasures of being here at Hopkins. And in a way, right, we're finishing a chapter. I'm being philosophical for maybe a minute, right? So that's a decade, right? I think it's an interesting thing that the end of any chapter is the beginning of the next chapter. So it'll be fascinating to see what people say today and what new studies it'll lead us to embark upon. And then some of you may know that I've done 3 of these chapters at Hopkins. So it's going to be 30 years on faculty right around today, right? And when I joined the faculty, Linda Fried was in the Welch Center, and I didn't know much about aging. I still don't know much about aging, but for some reason, they've chosen me to start an Optimal Aging Institute at NYU Langone because of a lot of these things that have converged on aging. So I welcome collaborations with all of you experts in the coming years as we work towards optimal aging. So hearing a huge challenge, in a way a simple design, but not so simple. Clinical trials, it's interesting. I think they're deceptive, and you'll see, not so simple. So basically, the idea was to build on Eric, right? And Liz Salvin has accused me that at any point I only have like 3 thoughts in my head. And Eric occupies like maybe 2 of them. So we were going to do this in Eric. Frank had all sorts of lovely things. I was like, why don't we do it in Eric? And it turned out it was pretty good. We measured the cognition in Eric, right? So we knew people were cognitively intact. We had the instruments, we had the staff, we had the facilities. We had done a pilot study in Eric. We showed we could do the intervention. We showed we had all the instruments. So everything was ready to go. But I learned one thing from the Physicians Health Study and other trials is never box yourself in, right? Because if you say you're going to recruit everybody from Eric, and we thought we'd recruit like 350 or more from Eric, it turned out we got, something like 238, maybe too few. So we were smart and said we will also recruit healthy volunteers. Now, we kind of should have known that for dementia, the super healthy volunteers who are running to you worried about dementia, there's been issues with them. And then basically, we then had 977 people. We randomized them, as Frank said, to either a hearing intervention or a successful aging health education control. And that was a fun session upstairs where we had to decide what's the control, right? And we actually ended up deciding we should have an equal number of meetings. We should have people feel just as good about this, right? And it turns out it really worked. At the end of the pilot, I met with these people who were at the end of the pilot, like, we loved the study. The sessions with Spencer were just amazing. And in my mind, it's going, that's the control group. And actually, we have somebody whose family member was in there, and she swears, and he said that he had his shoulder fixed because he had sessions with Spencer. And then they talked about health and they talked about other things, and they never talked about shoulders, but he actually got out and had the surgery for his shoulder that he needed. And then at the end of the study, everybody gets something because we can't let them go without hearing aids or any hearing correction for a while. So we decided on 3 years. And actually, this particular person, she also says that after 3 years, he then got the hearing aids and the family's loving. So there's all this subjective stuff, but that's anecdote. Now, what happens in a randomized trial? Are we filming or something that I shouldn't be in the middle? Apparently.
They couldn't hear you.
The mic.
Oh, the mic. Oh. Okay, next we may do a lavalier. Okay. All right. So then what did we do within Eric? I think all of you may know Eric because we use it so much. 4 sites, and we recruited within Eric. And so we have participants from Eric and de novo. The Eric cohort included 238 people, the de novo 739. All participants were informed that they would be randomized to one intervention and offered the other one after 3 years. And these are the inclusion and exclusion criteria, right? And the focus was on people with a mini mental score greater than 23, Let's see if we can get the pointer since I like to do that. With a mini mental score greater than 23. So we're testing people with relatively intact cognition, and the idea was to correct hearing early to avoid the decline for later. So we can't look at dementia itself, we're looking at the trajectory towards. Then the randomization was basically the hearing intervention versus the health education control. And I told you the idea was to sort of control for the Hawthorne effect and have equal number of sessions. You can look at the details in the paper. The study design was basically to look at baseline and every 6-month cognitive assessment, but the primary endpoint was the change from the baseline to the year 3. Both ends, you get the most power. Right? COVID happened in the middle, which made things even more complicated. But we initially said beginning to end. You have assessments every 6 months because if somebody dies after 2 years, you don't want to have nothing. Right? So in a way, you're doing all these measures, but really you're waiting for the last one. And we had a whole thing about what could be the rates of death, what would be the rates of drop in, drop out. It's really interesting. We can talk about that. And then there's secondary cognitive outcomes and other pre-specified outcomes, and we'll talk about those. The neurocognitive battery was extensive, and importantly, only a few tests involve auditory stimuli, right? So you shouldn't be failing it because you can't hear. And importantly, we verified speech understanding before doing the cognitive testing. These are the scores, and all tests are used to compute an overall factor score, and Alden was somewhere here. Worked hard on this in ERIC, and so he was like a number of years into that in general, a number of years in ERIC, and did a great job with giving us factor scores for 3 different domains with 3 tests each. So you can kind of align it all with latent variables. The incident cognitive impairment was our secondary outcome. This was defined by a composite of adjudicated dementia, in-person or phone evaluation, adjudicated mild cognitive impairment, or a 3-point drop versus baseline in the 30-item mini mental score in person or equivalent in the phone. And that actually turned out to be very tricky. It turned out making the phone equivalent to in person is not at all simple, right? So we ended up actually wanting to have the cognitive impairment be defined by criteria 2 and 3, and we required confirmation, so you actually failed twice. Right? Because if you went down and then recovered, that's not really what we think of as incident cognitive impairment, because incidents should stay. This is COVID, beautiful slide made by the team. Enrollment, we got super lucky, was before COVID, and this is beautifully shaded with mostly ERIC at the beginning and then mostly not ERIC at the end. So in a way, it's a perfect strategy. We'll see if we can do it ever again. To actually enroll with a running start because you have all these people. And then as you run out of ERIC people, you get more and more volunteers, right? And then that does mean that the ERIC people were followed the longest by the time they were assessed here. After COVID, we had the 3-year visit, which was really like a 3.5-year visit for them. And then saw everybody, and you'll see the rates. The analyses was basically for the cognitive outcomes. We estimated the effect of assignment to hearing intervention versus control based on change in global cognition using mixed effects, adjusted for baseline hearing, and a bunch of other covariates. The results are pretty much robust to the adjustment. It's something else that makes it much more complicated. Importantly, we had pre-specified sensitivity analyses, which we'll talk about some more. And then the secondary cognition outcomes, will show you those outcomes and the definition of p-value for the secondary outcomes. The recruitment, as I said, the target was 850. We went to 977. This study, you know, as we get older, we all have more and more stories. This was a great one. You know, we were going gangbusters. Look at this. The slope was here. And I was like, we're going to quit. And Esther O said, we were on a phone call. She said, nothing works. And I'm like, we're going to quit because we're overpowered because nothing worked. So I talked to Frank. I'm like, we should go for more. And Frank's like, how? And I'm like, we should just ask for more. So we called the project officer and we said, we want more. And she's like, but all your assumptions are okay. And we said, you're going to tell us we're going to be overpowered? So she said, no. She listened to us, and a month later, she went for it. And we got permission to go there. We were supposed to get to 1,000. We got to 977. And we're balanced by ERIC and not. And we've got the follow-up visit. So we've got the ERIC people randomized. We've got the other people randomized. Completion rate at 3 years after COVID, 90%. The Eric staff are unbelievable. They're really, really good. And the participants were great. So we are most grateful because we sit here in Baltimore and kind of take credit. Baseline characteristics by recruitment source, the Eric cohort versus de novo, right? So within randomization, within Eric, they're totally comparable. Within the de novo, they're totally comparable. But the Eric people are older. The Eric people are more female, and they're more African American. The volunteers who run to dementia studies are predominantly white, right? And they're predominantly more educated, right? 2% less than high school versus 9%. And they have more income, 20% over 100,000 versus 9% over 100,000. And you can see the other stars, right? The volunteers have less diabetes, they're less likely to live alone, and they're generally have a mini mental score that's a little bit higher, so they're healthier. What's interesting is, you know, in terms of cognition, they're actually above average, right? So we want people intact. The volunteers are above average. The Eric people, as you would think, if they have hearing loss and hearing loss is causing cognitive decline, they should be below average. So they start below average. The other guys start above average. You know, and the other thing that was the impairment is somewhere here. Do you see it?
Hearing handicap.
Hearing handicap, my handicap. So the hearing handicap, right? The volunteers are more bothered by the same level of hearing loss. So they are doing better cognitively. They're really bothered by the hearing loss. They're coming for the trial. So what happens, Frank?
But I think Joe's point there, no, there's still a microphone. So Joe's point there is really interesting, and it all makes sense in hindsight. I'll go back one slide. So if you look, the pure tone average, again, that's a measure of the objective measure of hearing. So you notice both, and the higher scores are worse. The higher number is the worse your hearing is. So you notice that both Eric and de novo, they came at the same level of hearing, right? But there's also something called hearing handicap, terrible name, but it's basically self-reported communication impairment. Do you feel embarrassed when you go with others? Do you struggle in conversations? So you notice though, and typically say scores above 10-ish are like considered impairment. You notice that the de novos are higher than Eric despite the same level of hearing, and it makes sense. If you're joining a hearing and cognition study, you're coming in because you're bothered about your hearing and things like that. So those are the folks on the right who were really bothered by hearing. Eric is actually, they weren't too bothered by the hearing, which again makes sense. They may never have joined the study except by virtue of the fact they're already followed Eric and they're phenomenal participants and the staff's so wonderful. They're like, sure, I'll join a study. Why not? All right. So first thing, in terms of beginning to look at outcomes, the first thing to really look at first is there any evidence that the hearing aids are doing what they should be doing, right? We always hear all these stories, my hearing aids are terrible, they sit in a drawer, I don't like them. And if that's the case, then we're clearly, we probably shouldn't see any treatment effect. So is there even evidence that the hearing intervention is even doing anything at the most proximal level of outcome measures? So one of the first ones, just purely just hours of use, right? So are they actually even using the hearing aids? So you see at 6 months, 1 year, 2 year, 3 years, this is obviously a sideways histogram. And you see the average out-of-hours use are pretty darn good. So 10 hours in the beginning, trails off 3 years later through a pandemic to ultimately settling in around 7 hours. And obviously there's a spread around it, but overall, yeah, they actually really are using, right? The same time, in terms of is that trickling down now to actually some improvement in communication? So remember I mentioned before, this is called the HHIE scale. This is a self-reported 10-item scale of communication impairment. Higher scores are worse. And what you'll see on the left there first is the gray is baseline, and then the blue bars are health education, the control group at 6, 12, 24, and 36 months. And what you see is that the HHIE score on average for people in the control group actually goes up a little bit over time, right? In contrast, you see with the hearing intervention, it drops at 6 months and it stays down over the entire 3 years of the study. The right figure is treating as a binary cut point. Basically, I told you again, anything above 10 is usually considered a significant impairment. So you see again at baseline, both the control and hearing measure group, they saw the same level of roughly impairment at baseline. Again, obviously, it makes sense of randomized. But then within 6 months, you see the hearing measure group sort of drop down, stay down, versus the controls actually even go up a little bit over time. Is primarily the hearing losses remaining untreated. Something even a little fuzzier, but just nice to see too. The very end of the study too, we also offered just this Likert scale, like how much did you like it per se? And we asked, how has a hearing aid changed your enjoyment of life? Is all administered not by the audiologist. So it's not really We don't think it's, you're trying to please your audiologist, offered by one of the staff members. How is a hearing aid change your enjoyment of life? And do the hearing aids with the trouble? So again, sort of softer stuff here, but again, nice evidence that they're clearly benefiting. They're using the hearing aids, and it's reflecting itself in terms of improvement in communication, self-reported communication function. All right, so that's good. The question is obviously, does that trickle across now to actually effects on reducing cognitive decline? All right, so this is the main summary figure, and I'll take you through it. So this is basically, and I'll read through it. On the left, primary outcome, global cognition, global factor score of the 10 cognitive tests. These are all standardized to baseline. So 0 is mean, and then everything is in SD units. So if you look at the control group, right, they declined over 3 years by 0.2 standard deviations in their cognition. The intervention group, 0.20 again. So when we saw this, I remember it was mid-April, it's a big like, oh, geez. But there's no treatment effect, right? No treatment effect in the combined cohort of ERIC and de novo, basically same rate of cognitive change over 3 years, about a 0.200 standard deviation change in both groups. If you look at the 3 secondary cognitive domains, executive function, language, and memory, basically again, the same thing, maybe trending a little bit toward memory, but again, clearly nothing to write home about. So this is the primary analysis by definition of combined ERIC and de novo cohorts. So again, not encouraging initially, but there's a big but. The big but is this, is that our pre-specified sensitivity analysis that was predefined a priori was that we would replicate the primary analyses within ERIC and within the de novo, because we always sort of recognize they're sort of different populations, right? We didn't realize quite how different they were though, right? So this is the summary figure here, and it's actually just qualitative, you can see the difference. So across in ERIC, you see a clear trend and statistical significance where the hearing intervention reduces cognitive decline and nothing in the de novo. So let's go over the top side first, right? So for the global measure of cognition in the ERIC group, right? The controls had about a 0.4 standard deviation change over 3 years. That's a lot. You may think about 0.5 standard deviations. That's a clinically significant change. It's just 3 years. The controls changed 0.4. The hearing intervention group in the ERICs changed only about 0.211. So that's where you get the 48% reduction in 3-year global cognitive decline in the hearing intervention group in the ERIC, but not necessarily the de novo. So then looking at the de novos, you'll see here again, the control group only declined by 0.15 standard deviation units, almost a 3-fold less rate of cognitive change among the healthy controls. I'm sorry, the healthy controls versus the ERIC controls. And again, in the de novo cohort, you're really seeing no effect of the hearing intervention on slowing something, right? So I think one key takeaway from this is this thing I mentioned before, is that the rate of cognitive change, maybe not surprising in ERIC, being at higher risk in terms of many different risk factors, is about definitely about a 2.7 or 2.8-fold faster rate of cognitive change in the ERIC controls versus the de novo controls, right? So one way of interpreting the results is that essentially, if you have no really appreciable cognitive change over 3 years, namely a 0.15 standard deviation change over 3 years, which is not much, you really can't slow that much more with the hearing intervention. The hearing intervention is predicated not on improving cognition, bolstering it, it's reducing cognitive change, cognitive decline over time. So you're in a group, namely the healthy controls, that aren't really changing much over 3 years. You can't really slow down something that's going quite slow to begin with. In contrast, in the ERICs, almost a 3-fold fast rate of 3-year cognitive change, and we're seeing about a 48% reduction in cognitive change over 3 years. If you look within each of the cognitive domains, right, executive function, language, and memory, you're seeing the same trend. It's interesting, and specifically in ERIC, the strongest effects appear to be in the language domain. So this is language production, this is naming objects, category fluency, right? So it's not receptive language, it's productive language. The language domain is a completely non-auditory task, right? So there are two of the 10 cognitive tests have some auditory component, and we control for as much as we can. We actually verify the understanding. But the strongest effects are seen in the one language domain, even which there is no auditory component. It's all language production, like finding a word, naming an object. So these are the results that are often sort of discussed in terms of you have a negative, you have a null primary, but then the sensitivity analysis within cohorts, you're seeing very different effects. You'll see the 3-way interaction is significant across essentially 2 of the global cognition, the 3-way interaction between intervention, treatment group, intervention and assignment to ERIC versus de novo is significant. for global cognition, and as well as language and trending for executive function. Oh, thank you. Yeah, I'm sorry. Bottom, oh, what else? Bottom here. Oh, geez. Yeah, there we go. All right. So those are our primary outcome is global cognitive function. We have 4 secondary cognitive outcomes. So we have 3 domain-specific cognitive scores, which are obviously highly correlated with the global cognition. The other one we actually looked at was adjudicated incident cognitive impairment. Joe mentions before fully one hallmark of ERIC in many ways is there has been long established with David Notman, Marilyn Albert, Tom Mosley, others, an adjudicated process for how cognitive impairment is adjudicated. So this is a composite measure. So either adjudicated cognitive impairment, MCI, or dementia, or a 3-point change in the MMSE, either telephone or the in-person, right? But it has to be verified the second doesn't ensure it's stable. But if you look at the sort of time to event of incident cognitive impairment in the total cohort, you see a trend maybe slightly, there might be a reduction in hearing intervention. If you look at stratified by ERIC NOVA, the first thing you notice for ERIC is there's a much higher rate of cognitive impairment. Again, not surprising, again, given the previous results. And again, a suggestion that you may be seeing effective hearing intervention here, but again, this is just 3 years. So clearly this will take a little longer to accrue of enough incident events to really tease apart, see whether or not this actually persists. Namely, you think, obviously, if you reduce cognitive decline, that could trickle down long-term to reduction in dementia risk, but clearly it's going to take many, many more years to assess. Don't forget, again, this is a primary prevention trial. These people all came in essentially cognitively intact. So it's going to be many more years before we can see an outcome of this sort of come to pass with enough events. So a few quick summaries of the main cognitive outcomes. So on the total combined cohort of ERIC and de novo, hearing intervention had no appreciable effect on reducing cognitive decline within 3 years. We did see in ERIC, though, very, very strong effects. Basically, 40% reduction is a large effect size that we actually did not anticipate that big. That's the only reason why it's actually so significant. The fact that you only have 238 people and you're seeing this strong of an effect is the only reason why you're still seeing significance at that level, because it's such a strong effect size. But it suggests that hearing intervention might reduce cognitive decline within 3 years in populations at increased risk for cognitive decline. This makes sense. If you're looking at a population at very low risk for cognitive decline, you're not going to see an effect of hearing intervention reducing that decline any further within just 3 years, maybe 5, 10 years. But the only way you're going to see an effect within 3 years reducing cognitive decline is has to be predicated on your population already must be having some cognitive decline over those 3 years to have an effective reduction on. No effect observed in de novos. And again, one thought here, one interpretation is a slow rate of cognitive change may limit the ability to observe any positive effective hearing intervention within just 3 years. Again, mentioning here, if you look at the annualized rate of cognitive change, de novo controls about 0.05 SD units per year. So it takes 10 years to decline half a standard deviation versus almost a 2.5, 3-fold faster rate in ERIC. That corresponds actually nicely to the literature. Kate Hayden, who's one of our investigators at Wake Forest, a nice paper a few years ago, I think it was in the Women's Health and Aging study. Basically, those standard deviation units change per year roughly corresponds to what we consider a slow versus a moderate rate of cognitive decline. And then in terms of reasons why de novo declines so much faster, I think one natural interpretation is very much the idea of a healthy volunteer effect. I mean, we're recruiting people from registries, so people are interested in aging dementia studies. We're recruiting from Facebook ads, so you're really self-selecting for a population of older adults at that level who are probably honestly just more cognitively intact, more health conscious to begin with, right? So very, very different population than ERIC, based on the demographic risk factors, based on baseline cognitive, everything points to this very much idea of a healthy volunteer effect. One thing I'll mention here, which we don't really bring up, we haven't brought up before, but another thought, and this may be further fodder for discussion too, is along with the healthy volunteer effect, a key thing to remember too is the healthy volunteers, this was a cognitively testing naive cohort. And what probably many of you guys recognize from cognitive testing is there are true practice and learning effects that can carry out even 2 or 3 years later where people stay stable or they even quote unquote get better over time, right? So how much for the healthy volunteer cohort is actually, are they really not declining or are they actually just still improving because of cognitive practice effects? Whereas in ERIC, by virtue of being followed for 30 years, right? With the same battery we've done now at least minimally 3 times since 2010, any type of practice effects you're going to get at that point are pretty well washed out at that point. So you're seeing a much truer level of cognitive change in ERIC participants because you're not getting practice effects anymore for 30 years. Whereas de novos, are they really not declining? Or some part of it too is that the practice effects is they're still getting a little better, which will mask any decline. Hard to say which one it is. Clearly, the healthy volunteer effect is undoubtedly true, though, based on just purely the baseline demographic factors, though. All right, some limitations, as always. So clearly, the effects of the hearing intervention for populations that decrease risk for the de novos, it's going to take longer to follow up, right? As well as anything whether it trickles down to actually rates of cognitive impairment, dementia diagnosis, where it's going to take longer than 3 years to follow up. The control participants, one argument too is, well, maybe they just more poorly because they couldn't hear the stimuli. 2 of the 10 tests had some auditory stimuli you couldn't avoid. Again, that was hopefully guarded against because we always actually measured and ensured their speech understanding before they did a cognitive test. And also, I mentioned before, in ERIC, the strongest results were when the language subdomain, which has absolutely no auditory component as well, right? And finally, for probably pretty practical reasons, we couldn't mask the participants or the staff to intervention assignment. I will mention, this comes up right now, we did try though. Actually, there was a debate when we did a pilot. Do we have, it's gonna sound ridiculous. Participants, when they come in, they would wear a shower cap over their ears. So the testers couldn't see whether they're using hearing aids or not. We considered various things, and all of them in the end were considered as completely and totally non-feasible and not practical. So this is a non-blind study in that perspective. I mean, the psychometrists could tell someone was wearing hearing aids. The people getting hearing intervention obviously knew which one they're getting to, right? So that's always going to be an intervention that's probably not overcome by any practical means. You're up, Joe.
Other health outcomes.
Other health outcomes.
Loneliness. I don't recommend it. And by the way, for the group, I don't know how many people have watched the Blue Zones documentary on Netflix. Interesting. And I think it's interesting to connect sort of this global thinking to scientific thinking.
That's fine, I interrupt you, but if you want to walk around, we can turn that owl on and then that's would you prefer that for this question?
I think we'll be okay for a while. But I mean, if you want to turn the owl on for discussion, maybe that'll be good later. Okay. So loneliness and social isolation were important secondary outcomes. We used the 20-item UCLA loneliness scale. The score ranges from 20 to 80, and higher scores are worse, right? And you have categories that have been published for, high loneliness is 65 to 80. The neat thing is that overall, the result favors the intervention. With lower loneliness, the intervention stayed the same and the control got worse. It wasn't different by ERIC versus de novo this time. The ERIC group is smaller, so higher standard error, but absolutely no interaction. However, we have to admit that on an 80-point scale, a difference of 0.39 is not large. Social network characteristics, the idea was, would people sort of narrow their social network or narrow their social network diversity because they couldn't hear? 2 different scales. Higher scores are better social networks, larger and more diverse. Conveniently and neatly, the result was favoring the intervention. Again, no difference between the ERIC, where actually it was a little bit bigger, but no interaction whatsoever. Statistically significant p-value of 0.04 for a larger size of the hearing network by 0.37 when the hearing network size is a 0 to 84 scale. So not a lot, but statistically significant. And then the network diversity was also decreased in the control and did not decrease overall. This was significant in one group, close in the other group, no interaction. So no evidence of a difference for those. So summary and conclusion.
I'm motoring along, Joe. It's good. All right.
Here it's the discussion.
All right. So summary conclusion. Key findings. So we start at the top. So I mean, in terms of the proximal measures, there's clearly what we saw. There's high adherence to, and actually, sort of squishy satisfaction with the hearing intervention, which I think is key because I think we always hear with hearing aids, people don't want to wear them, whatever, but actually sort of counterpoint to what we saw here. I think part of that has to do with essentially the rigor of the intervention, audiology providing every 6-month visits, really following with participants. It's not just here's your hearing aid, see you later in 3 years sort of thing, which is actually what happens, unfortunately, really in practicality sometimes in how the retail industry works. We did see very clear positive effects on self-perceived communication function. Also, as well, Joe mentioned, especially on loneliness and social network size and diversity. All these proximal measures of cognition, we're seeing very nice relatively robust positive effects of hearing intervention across all of these. These seem to be carried out downstream now to in terms of for the ERIC cohort, which actually had cognitive decline over 3 years, nearly a 48%, nearly 50% reduction in 3-year global cognitive change. Again, for the de novos, one possible reason for not seeing a benefit is they just really had no cognitive change essentially over 3 years, basically a 3-fold slower rate of cognitive change, and or is partially part of that being masked too by basically just practice effects over 3 years are actually still staying stable because those practice effects mask any effect that hearing intervention could do to reduce that decline. Key inference here that was presented in the final paper and a lot of the press media coverage is that hearing intervention may reduce cognitive change within 3 years, so a relatively short period, for a population of older adults at increased risk for cognitive decline. And what's predicated that all is that to detect reduction in change in 3 years, there actually has to be some decline in 3 years. So those will probably only be seen relatively in higher risk populations. We're not going to see in 50-year-olds where no cognitive change, you're going to see no cognitive benefit in 3 years, there's no decline to be had. Older adults, if you're actually at risk for cognitive decline, you'll actually see some benefits in 3 years. Others may too as well, but it's going to take a lot longer than 3 years to see or monitor for an effect. Implications. So broadly, I'll say the findings are very consistent with the 2020 Lancet Commission on Dementia, as well as our 2021, the U.S. National Plan to Address Alzheimer's Disease funded by the NAPA Act. Very consistent with both of those about calling for addressing hearing in essentially national dementia risk reduction strategies. Again, I mentioned before, hearing loss in particular is actually a really appealing target because it's really, really common. It's highly prevalent. There are established interventions that are underutilized. Less than 20% of people currently report using hearing aids. The hearing intervention itself is literally with zero medical risk. And also it has benefits on other domains, well besides cognition, basically communication and safety and things like that. One broader policy issue that we're still working on is the need for insurance coverage and what that means for Medicare coverage of private insurers. Importantly, the coverage of really has to account for the services the audiologist provides distinctly from the hearing aids. So 2 distinct components, both are essential, but both are very different, and how you fund it likely affects the cost actually in the very, very end. We'll talk more about that if people are interested. What's next for Achieve? I'll say we fortunately with Joe again, we have another 5-year grant from the NIH funding the entire long-term follow-up of the Achieve cohort for another minimally 3 years. So we actually got these it was actually strategic. It was actually not a renewal grant. It was actually a separate grant. So actually there's an overlap period, which kept it completely seamless in terms of long-term follow-up. As many of you know, if you ever do a renewal grant, there's some latency lag sometimes. We actually applied for 2 separate grants for this. So the second grant, which funded it, the long-term follow-up, was actually not a renewal. It's a separate process. So it allowed for there's some temporal overlap by, I think, about 6 months or so, which made it really nice. So there's a seamless follow-up in the entire Achieve cohort. That allows us to continue studying serial MRI scans and all the other outcome measures we measured before. And clearly, the longer-term follow-up with the entire cohort is going to be needed if we're observing for intervention effects on sort of very distal outcomes. Actually, cognitive impairment, dementia will take longer to observe, as well as what it means for the healthier de novo cohort, which as they get older, you can imagine everyone has some change with enough time. And again, the 6-year follow-up study is underway. So again, I'll give final acknowledgements here again. Joe and I mentioned before, we represent a much larger group that's been together for almost 10 years doing this trial. It's crazy to say that. These are all 10 years older now. But it's a consortium about almost 8 different universities now, 7 plus Mayo, which is our MRI reading center. That photo actually is back in the days we used to be in person. So that was from 2017. That was our kickoff meeting nearly 6 years ago. That represents probably about half the amount of the staff and investigators were at that one meeting. I will also hear the funding from the study has come very generously from the National Institute on Aging, as well as from the MRI ancillary study. ERIC has been the backbone of which the entire study is based. I think it's one of the few examples you see in the literature where you have a clinical trial embedded and nested within an existing observational study. It makes for incredibly efficient science. It can't always be done because you got to make sure that the investigators line up, the intervention is relatively orthogonal to the main goal of the observational study, which actually worked out well. ERIC was founded on cardiovascular events, not cognition necessarily directly, so it was fairly orthogonal. But it does make for a tremendously efficient science. One thing, analysis we're beginning right now, which makes it very scientifically powerful. A lot of this is very pragmatically powerful, but scientifically powerful. Another thing we're doing right now is for ERIC participants, they have their previous 30-year trajectories right? So you have the previous trajectories and you treat, half get the hearing loss treated, do you actually lead to a knot or an inflection point in terms of long-term cognitive change, functional decline, once you get hearing intervention, right? And you typically can't do that in any RCT. Or RCT is typically you have your baseline and then bam, you go right to hearing intervention. You don't have a 30-year like wash-in period per se. But that's actually we had that with Eric right now. We're beginning those analyses right now as well. Finally, I mentioned all the devices for the study were donated in kind from Sonova Phonak. So NIH usually typically expects if you're going to do a big device trial that companies going to donate devices. That what happens. Sonova Phonak, which is the largest hearing manufacturer in the world, they were a phenomenal partner from the very beginning. Through MTA with Hopkins donating all the devices in kind, which is literally quite a large donation in the end, given the size of the study. And finally, this was actually, we like this. This was the cover of the Lancet when it came out just last month, finally. But it's a nice sort of crisp sort of summary of what we think the final inferences and results from the trial are. Thank you very much, guys. Appreciate it. So Joe and I will come here and share the microphone. So questions, thoughts? Oh, sorry. Oh, sorry.
I'm muting this one.
Steady.
The owl on?
Oh, the owl.
Is this one Fiona or the other one? No.
We
We won't name the owl.
That's the name.
Go ahead.
Enzo.
Oh.
Steady? Yeah, sure.
Yeah, first of all, congratulations. I mean, it's fantastic. Perfect and perfect presentation and your recruitment. I have two questions. The one is, your patient tell you they're wearing it for 7-8 hours, which is very impressive. I know some of the hearing aids, they record. Have you checked it?
Yeah, so you're spot on. So basically everything that was reported was self-reported hearing aid use. We can also collect something called data logging. So basically every time the hearing aid is plugged in, it can be interrogated and reports back to the last time point hours of use, right? Averaged out over the course of a day, right? So we can do that. And actually it's overall very consistent. It's slightly less maybe by a bit, but there's also some variance too. Because some people think their hearing aid is off and they forget to turn it off. So then it tracks that too, right? And then some people like the hearing aid might have cracked when they last came in, so then erases the data. So we typically use a self-reported because it's much more complete data. But if you take a subsample and you look at like the interrogated hours of use versus self-reported, it's actually pretty close overall. It might be off by a little bit, but it can cut both ways though. So, but overall pretty good. Yeah.
Thank you. That's good. And the second question is always, the mechanism, it's like, so the Eric is, I mean, I don't have to tell you, it's a vascular rich, so have you thought, I mean, to follow or maybe do yet another study to enroll people with MCI caused by maybe an Alzheimer's pathology and look if there's maybe whatever the pathology is driving it, and not, what is the underlying mechanism, what is your hypothesis? Is it vascular, Alzheimer's, or whatever? So it's just thinking out loud.
So you might have really answered it too, but
We're not gonna agree on everything.
No, yeah. So one answer is yes. So studies are already underway. So there are two studies I'm involved with. So one is it's an NIH sponsored study. It's done by a group up at Columbia. So they're selectively enriching for only MCI patients, right? And then they only have 1-year results, but they're also doing fMRI as well. So looking for other biomarkers in a sort of an at-risk enriched population. So that's ongoing. Actually,
What's the control?
They took our entire, in a good way, I'm on their grant, but it's the exact achieve protocol. They have our Vicky Sanchez, who's led the hearing intervention at USF, she's running hearing intervention, control groups from Nancy Glynn. It's achieve, I should say achieve right. It's achieve MCI 1-year outcome, but really looking at fMRI as a nice biomarker. That's one study ongoing. Other one's actually in the UK, funded by the National Health Service. So that's actually recruiting again patients already with clinical MCI from clinical populations, and looking at sort of the same, roughly the same design as well. So those are all going, yeah. But Stevia, to your point, I think mechanism is tricky, right? And then I think we'll be teased out, I think, in the next maybe months in the year ahead is we're still dissecting all the achieved results. I mean, one thing that Joe mentioned a little bit and was alluded to in the beginning is we have a whole capture range of outcomes. So the cognition is a big one, obviously, but then we have biomarker data, we have MRI data, which I'll show you a little bit if you guys are interested, as well. So we can begin teasing about the mechanism somewhat with this existing study, and then going for the long-term follow-up, maybe even a bit more, actually, some other measures we're gathering. I thought you were thinking about proteomics or the omics.
No, I mean, so great question. I think it's an interesting question as to what's the follow-up, right? And I think it's very much to Frank's credit and the team that this is not a shallow trial, right? This trial added MRI, added lots of measurements. I think it's also fascinating for those of us who have done observational research for decades to kind of see how it connects to the trial, right? And how the framework is actually quite useful. And I think nesting could be an interesting thing for a lot of trials and interventions. So we'll talk more. Let's hear the question.
Well,
Yeah, I had a question about your control group. You showed your mechanism slides like Kevin was talking about, and the third one is the indirect, the social aspect of it, that the hearing aid would, or hearing intervention would help. And I wondered how much does your control group overlap that mechanism? And whether it's actually slowing cognitive decline.
Yeah,
as well.
yeah. This was a very conservative control group, right? I mean, in the sense that they really, it wasn't a no contact control, see you 3 years later sort of thing. I mean, they had the same amount of intensity of exposure study personnel. I mean, both groups, right? So and it's hard to avoid that. I mean, obviously, as we're planning this trial years ago, one option was a no contact control group. See you later, see you in 3 years sort of thing, right? Just ethically, it's harder, right? Quite simply, right? On top of that, pragmatically, it was just unfeasible too. There's also, again, the balance between a balance in the end. But you're absolutely right. I think if anything, this is a very conservative control group. One thing that it's hard to see before it came up is there is a fair amount of drop-in. So this trial, the people in the control group who dropped in, basically meaning, forget this, I'm not waiting for 3 years to get your free hearing aids, I'm gonna get hearing aids of my own. There was about 15% drop in over 3 years, right? So 15% of people in the control group end up getting hearing aids on their own before the end of 3 years, which you can imagine is going to dilute any treatment effect, right? So that, there's no way to get around that. The only way we got around that was by inflating the sample size. So that was actually factored into our sample size considerations. But you're seeing a relatively conserved control group by virtue of all those factors. Like they're getting something really, as Joe mentioned, people actually like this sexual aging intervention. They may have a health educator, panel and sessions. It follows curriculum that was developed by the CDC many years ago called the 10 Keys of Clinical Aging. It's actually a real program for how you educate older adults about health aging topics. So they actually got that step-by-step one-on-one health educator. And then on top of that too, well, actually, like I said, a lot of 50% of them actually get hearing aids on them too. Of which you can imagine too, among the de novos versus the ERICs, the rate of drop-in was higher among the de novos too than the ERIC, right? So again, you are possibly seeing a very conservative effect and dilution of the treatment effect as well. But
Yeah. But among friends here, you know, when we were designing it, there was a lot of hand wringing and thinking, but in my mind, right, if you can get an equal slowing by getting together in a group without a hearing aid, then you're not getting protection by the hearing aid. I actually don't think, you know, it's conservative, but I don't think we slowed cognitive decline that much. If we could do that and nearly halt cognitive decline by just having like 6 meetings with a person, that would be great. I think it could be promising over many years, et cetera, but I'm actually becoming more and more a believer that to keep people in research, you have to give them something, and you have to give them something meaningful. And I think we can't be afraid of giving them more. So I'm actually quite okay with that part. I think for me, the thing to learn was, it was true in kidney disease. For us in kidney disease, proteinuria is the measure of progression, right? And you have to have progressors to reduce progression. I think for me, that was always true. We knew it to begin with. We didn't select here. And then you could talk about the whole argument of, should the follow-up to this be personalized medicine? And if it was a medicine like some of the new Alzheimer's medications would have a real tricky risk-benefit profile, then I'd say yes. But here, it's the kind of thing where if it doesn't help now, it might help later, and it helps you in isolation and it helps you in perceived handicap, then I don't know that personalized, but on a societal basis, the idea of the worried well are well for a while, I think.
you know, the question that came up to, it came at AIC meeting, which was, I think was really pertinent, is that, you know, for most, you know, you can imagine AIC, most of the intervention studies are either, majority are pharmacologic, amyloid reducing therapies, right? And there's a smaller subset which are more non-pharmacologic, like Achieve, right? And then a great question we got from the audience was, you know, a lot of the Alzheimer's lowering agent, amyloid lowering agents, they enrich, right? They enrich a population, they just select based on beta amyloid positivity, to even join the trial and things like that, right? And the non-pharmacologic studies, it's a lot harder for how you enrich, right? So obviously one way you enrich is you get people who are already showing cognitive impairment. That's also, you're pretty far advanced at that point. So, you know, the person brought up 2 points is that how many non-pharmacologic studies in the past have failed because we've not given sufficient thought to the recruitment mechanisms for how we get our study population. I think it's a real one. It really, really is, right? Because ultimately, yeah, you sort of got recruitment, you'll take any you can, right? And the hard to reach people are usually the people at the greatest risk that aren't reached. And then, you know, case in point, joining our presentation at AIT in the afternoon session was the MIND trial, because we're following it, the MIND diet. That actually is published in the New England Journal same day too. That was actually a null finding, right? But again, the studies, how much of it is from really failure, which could be from the mechanism, the intervention, or is it really just a fundamental study population is gearing much more toward this healthy, really cognitive healthy population? You know, another paper that comes up sometimes people mention is another non-pharmacologic intervention trial, which has showed some positive results besides obviously Achieve recently, is way back when the Finger trial, right? And the Finger trial, well, it's complicated, but you know, they enrich their population to be in the study. You had, I think, the 0.1 standard deviation below the population mean. So that's another way of doing it too, but it just makes it adds complexity. But I think all too often, I think, at least in non-pharmacologic intervention trials, not enough thought is given very closely to your study population recruitment, right? I mean, because you're sort of a recruitment, you don't take anyone, right? But as you know, David Notman said this to me. He's sort of joking about it, but you know, he's very dry. He's like, Frank, if you ever want to see a healthy cognitive population instead of a dementia study, right? And it's true. You really do get the worried well who come out of the woodwork for those studies. Yeah.
I have a question.
Very nice presentation. Curious what thoughts went into individuals who may have been experiencing hearing loss or subjective hearing loss for several years prior to the intervention compared to individuals who maybe a week ago. I feel like I have, issues with my hearing. And if you've done the analysis trying to look into whether you need to catch hearing impairment very early on, or I have hearing impairment for 5 years, boom, give me a hearing aid and stave off cognitive decline.
So great question. So hard to tease out, and what I mean by that, well, so yes and no. So for the classic age-related hearing loss, it's a monotonic decline that really begins in our 20s and 30s that happens over the course of a lifetime, right? And that really is the steady state for a lot of people, no matter who you are, right? The other extremes, people present with a sudden hearing loss medically for some reason, a sudden infection, a sudden viral infection in the inner ear, and things like that. Those are much, much less common, and those usually present asymmetrically, as opposed to, it's usually not both ears all of a sudden really get bad, short of obviously you'd be exposed to chemotherapeutic agents or something like that. It's relatively rare. So at least for the Achieve trial, some of the inclusion criteria from the very get-go was no substantial asymmetry, no medical issues that could lead to hearing loss, things like that. So I think we're really capturing here, and this is 99.9% of people out there with hearing loss. It's the slow age-related garden variety, not from a sudden cause from the last few months or few years. Those do happen, don't get me wrong, but almost always though, those are going to be unilateral, right? And you'll get asymmetry, and those were really excluded from the trial for the most part. Yeah, so we think this is probably a garden variety, like just slow, gradual onset of it. That being said though, and there's no congenital hearing loss too. So at the extreme, no one was born with a congenital hearing loss. The trial itself too, obviously to be in the trial, you couldn't have, your hearing had to be unaddressed so far, right? So no one intervention to that point. They might try it in the past, but no one had any hearing going to the study as well.
Thank you.
Yeah, great presentation. I think I have a couple questions about adherence.
Mm.
So you had pretty good adherence overall, but also quite a bit of variability. Did you look at differences between Eric and de novo adherence?
Oh, yeah. So it's interesting. So the de novos actually have, you can probably guess, higher rate of hearing aid use over time. Yep. And then if you look at like their we didn't show it here, but if you look at so they have high rates of hearing aid use, the de novos versus the Eric, and again, it makes sense. We're worried about their hearing aid, the hearing aid like that. And then if you look at the hearing handicap scores, right? remember, Joseph earlier, the Eric Pearsons actually started lower than the de novos. So both groups dropped after hearing intervention, but the de novo group drops even more, right? So they were, if anything, more adherent to treatment, and that was reflected actually in terms of their improvement in communication function as well. The Eric group improved in terms of communication function as well, but not to the same degree, because they had less, they started at a better level anyway. Yeah, but the rate of actually hearing it is actually higher in the de novos.
And I guess my second question is, so I was looking at those adherence charts pretty carefully, and, they're pretty high, but they do go down, and the bars of zeros are pretty high in the later years.
Yeah.
So as time goes on, the intervention gets diffused. You mentioned you have some of the controls that are on their own buying hearing aids.
Yeah.
Then after 3 years, all the controls, at least access to the intervention if they want it.
Yeah, yeah.
So how are you gonna handle all this stuff in your long-term follow-up analysis?
So, yeah, so the long-term follow-up is not a clean trial anymore. What you're really looking for is, we're looking at lag effects, right? Is there a lag of effects of earlier intervention versus later intervention in terms of that? I mean, because you're right, this is not control versus intervention at 6 years anymore. Right? We couldn't ideally, we love to say, okay, you can't get hearing aids yet. We pragmatically couldn't do that, practically and ethically couldn't do that. So yeah, the actual 6-year analysis is really predicated on a lag effect more than anything else.
So it's gonna be more almost an observational study than something.
Yes, some of both, right?
Yeah.
And I think that, right, the trick is to both write a grant that's compelling enough and then actually enter it with enough understanding of the nuances to do the right thing. Even though I think often what you have to say in the grant has to be simple enough. So there's actually the beauty of, I believe what we said, which was, we said the result wouldn't be fully definitive at that time. Took a little guts to say that a year before the study was out. We argued that under any scenario, we want to know more. I do agree that under any scenario, 6 years of follow-up will be better than 3. The randomized thing is just a lag by 3 years. But it's interesting, it is possible that it takes a while for the benefit to happen, in which case there'll be a big benefit. And then it's interesting that you can both look at long-term outcomes and nested within ERIC with an ERIC comparison. So as an observational study, an intervention makes a very interesting non-randomized observation study. And there's imaging, and there's biomarker, and there's functional stats, and there's secondary, and there's how they come.
Richie's.
I think people online have questions. We're just trying to.
So I think we're in overtime, but I don't know how long you go, we can stay.
It's really going to 5 o'clock.
Fine? Oh, okay, cool. So we'll figure out the next study, this is good.
Correct.
I think that Moises had a question.
Yeah, actually, I have a comment. It's interesting that in the ERIC sample, not everybody benefited from the intervention. So it would be really interesting to, of course, an observational analysis, to look at the characteristics of those people who did not benefit from the intervention.
So first of all, by way of background, people should know that Moises was the chair of the ERIC steering committee when it started in 1986. Except for Richie's on there, who designed the ERIC study in 1984. So he's not the first. And Moises also has had hearing aids for a while. I remember during seminars when I was younger, you knew the speaker was not interesting when Moises was playing with his.
Actually, after hearing your presentation, I'm really happy that I wear my hearing aids 14 hours or 15 hours every single day.
So you can talk more. I think the amazing thing to me about trials is, right, when you do medicine, people think that every patient benefits from what you do. And then Fred Brancati, who was here and great and funny, talked about it like in diabetes. He said, uncontrolled interventions for diabetes and weight loss, 80% of them work. You do the most rigorous, randomized, well-designed, thought out by the top scientists, 80% of them don't work. Which tells you that there's a whole gap between perception and what may be Hawthorne effects, placebo effects, et cetera, that actually showing a big difference is hard. So I think, Moises, I'm not that surprised that a lot of people didn't have a difference. Measuring cognition is hard. Measuring over 3 years is hard. Alden may be able to comment. You're seeing a lot of noise in addition to actual progression. So we can try, but I'm not sure we'll be able to distinguish people well.
Thank you.
So you talked about quantified adherence to the intervention by in terms of wear time, in terms of hours. Is there a particular way you thought about adherence to the 10 key steps? Maybe because, for example, if there is someone who is, yes, I'm coming to the visits and I'm paying attention and following those steps versus, well, I'm just coming and not paying attention or being bothered by the teaching given to.
Great question. In short, not really. I mean, there's one crude one is whether they showed up for the booster session, which overwhelmingly did. There is one self-reported metric per se of how much benefit they found from the health education intervention, but really no other way to quantify besides just a binary, do they come for the visit and things like that, as well as the self-reported. They're all like, I don't think we'll get into it, but theoretically, the 10 keys, every time they came, they picked a different key, which they wanted to do. So that actually is captured somewhere. I don't know what to make of it one way or another. People pick the keys they're interested in, obviously. But no way of really judging compliance or adherence with that intervention besides that, though. Yeah, your question.
I have two questions. So did you look at the factors that's associated with adherence with hearing aid use, like those hours? Like those people to drop to 0 hours,
Yeah.
like what's
We actually have not. In the same breath, I'll say we are very open to ancillary proposals right now. So, I mean, you just mentioned that we published one paper, actually one paper, the 3-year results for that's it. It's really a gold mine of data. There's a lot of data here which we haven't done. Right now, we're purely focusing, Allison Huang is really leading the whole analytic team right like that right now, along with James Pike is we're focusing right now on getting all the other main intervention papers out, like hearing first control on socialization, loneliness, depression, brain MRI. I mean, it's like 10 other papers they're minimally looking at, again, a very clean intervention for control on, you consider exploratory outcome at that point. Then beyond those 10 papers for the next 6 months, it opens up to all sorts of observational analyses. I mean, the non-people here from the auditory space, there's nothing like this. There's never been a hearing intervention trial ever done this magnitude beyond a few months. So there's an incredible amount of rich data there, even down to the hearing aid data logging, wear time, exposure, noise exposure. I mean, the acoustic ambient environment is captured. There's a lot. We have Amal and Jennifer working this. We have actigraphy as well, annually as well. So there's and the brain MRI too, and biomarker data. So we haven't even started touching those other, let's say, secondary observational analyses. But if you're interested, let us know.
I was curious.
Yeah.
The second question is also just curious, have you done the protocol analysis to look at people who are actually wearing given the huge size of drop-in?
So we did per protocol analyses, also compliance average causal effects analysis, which is really, this is James doing all that. We didn't show it, the results get stronger. Yeah, they go in the right direction. Yeah.
I was wondering if you have thought at all about kind of sufficient dose of hearing aid use for seeing an effect, because I know you spoke about how this intervention kind of goes a lot pretty far beyond what people would get in clinical practice if they just got hearing aids. So I wonder if that's something that you're thinking about as you have more follow-up.
Such a good question. I don't know. Right. And I'll tell you why. The reason why it's unknown too is because it all depends on the mechanism it's going down. Right. If the main mechanism that hearing intervention may be reducing cognitive decline is literally auditory neural brain stimulation, you can imagine more is better. Right. On the other hand, if it's through fostering greater social engagement and activity, wear time may not be as part. These people have different lifestyles, right? If you're just going out now once every other day because you can go out to dinner, but the rest of the day you're not wearing it, then it doesn't really matter wear time. Depends on the time you wear it that matters, right? So that's really tricky to tease out, right? So that gets into really looking at underlying mechanisms. Do they mediate effects on, let's say, cognition? We have those planned. I'm guardedly optimistic what we'll show though, because it's a lot of nuance there. Those mechanisms that come down to it, there's evidence for all three. They're not mutually exclusive. How it trickles down to effects on cognition, it could even be variable from person to person, right? So I think my gut feels we'll never get to the point where we can classify a dose threshold we need because those mechanisms are widely variable and they vary from person to person.
I mean, just to expand on the dose thing, and actually we stand in front of the speaker, but actually I think now we should talk to that. Yeah, and it follows you, you know. Did you notice that? You go to the second screen and it gets you on the second screen. So I think, right, the number one thing for dose is probably duration. Right, so deciding on 3 years was a decision. The other part is COVID may have changed the dose a lot, because you were talking about the lifestyle. If people didn't interact as much.
Yeah.
They may not have been in noisy restaurants nearly as much. And so that wouldn't be as big an issue. You know, so we'll have to kind of see, and in some sense for dementia, you'd think you'd want like many years of exposure. But that was a big thing when we started was, could you, right, to be eligible for this, you have to be over the right age and have significant hearing loss, and then be willing to be randomized to not get a hearing. Right, and so the question is, how long can you do that ethically? And I think conveniently enough, the state of the art in this country is that the vast majority of people get nothing. So we felt comfortable enough saying, if you're willing to wait, and we'll give you something in 3 years, we'll do it. But it wasn't easy and clear that we could achieve this at all, I guess, on not intent.
Did you do an exit interview?
Well, the trial's still ongoing though, right? So everyone's still in the study, actually. Well, people are actually, not everyone's joining the follow-up study, but everyone is being invited to continue follow-up. So there's really, the study's still ongoing, actually. So we haven't really done a formal exit interview since after 3 years, what do you think? Except for some of those scales we showed you. But because it's ongoing, we haven't done a formal exit interview beyond that.
But there are questions at every visit. Which questions are you thinking about?
I mean, how they're going through the intervention or the parts of the like better. Are there, you know, other hearing aids, how do you like the hearing aids? Is there anything that they will do differently, that they will want more?
Yeah, and we spoke to the staff. I remember speaking to staff, especially when we knew the results and the staff didn't, right? I think all in all, I think one of the impressive things about this is that, right, the vast majority of the people wore the hearing aids and for substantial number of hours. And it wasn't just the motivated volunteers, it was also the ERIC people where we identified them. Now, even within ERIC, not everybody who was eligible took part. But it's interesting, you take ERIC, people have been studied for a while, you give them a hearing protocol, you test them for hearing, you tell them they don't hear well. You'd think ideally they just go and get like a hearing aid on their own. So then if they did that, they're out of the study. Obviously, minority did that. Now you tell them, we're gonna randomize you and potentially give you hearing aids that are worth thousands of dollars. Half the people are like, no, not interested. Right? Then of the ones that are somewhat interested, it seems like the half that were randomized really picked that up very well. And my sense from the staff was that people really liked it. But they also liked the other stuff. The attention is important.
Yeah. I think that was a credit to you. I mean, one thing we're most proud of, Joe and I, is like after Joe brought me, but after 3 years through a pandemic, the rate of follow-up at 3 years, 90%. I mean, that's crazy. We had predicated this trial on 10% attrition per year, 27% over 3 years we predicated on, and we had 10%, right? And it's a testament, I think, really, I think listen to the call. It's a staff that makes the trial really work in the end. I mean, the staff like making business feel valued. We would pay for transportation for a car to pick someone who couldn't get a ride in, right? So that's huge, right? So I think, you know, Joe's always been on the soapbox to treat the participants as well is really, really key. We sort of forget about that sometimes, but that's what Eric has always done so well, which explains the rates of retention and what from side point, the high level data we're getting, more from some point of view, they feel valued in the study.
But I think that's, you know, talking to Melissa, right, and to a group that talks about aging. If you look at response rates by aging, one of the people leading our recruitment committee shows that response rates by age go way down. And they go down to like 20% at over age 95, right? Because it's hard to come for a visit. And then if you talk to some of the investigators, they were analyzing response rates by burden. How many minutes are you engaging the participant with the idea that the more minutes, the more burden, the lower the response rate. Me both being stubborn, and Fred Brancato used to say, one of the best motivating forces is enlightened self-interest, right? We want more data collection, right? So to me, the question is that really the biggest problem? The more data you collect, the worse it's gonna get. Or the alternative theory is there's burden as one metric. The other one is engagement. The other one is value. And the other one is whether they like the whole thing. And I think the proof in Achieve is we had bigger burden than ERIC by a lot. But in ERIC, we're struggling to get 50% response rate. Here we got 90% response rate. So clearly to me, if you give people what they want, they will return. So I think the challenge in ERIC, and I think in all our studies to me, is to make sure that there's what we want. And then there's what the participants want. And I think we actually have to spend money on what they want, right? So like in ERIC now, I'm trying to tell the investigators that we will spend some of the money that we had from carryover on a social worker that will help the staff understand the resources in the community that they can explain to the participant. So when they come and they have a problem, you don't just say, thank you very much, we know you have a problem. It's like, we've always done some, we've always given some brochures, but meaningfully investing in being able to do something for people, right? Even though it's an observational study, but I never worry about the idea that, oh, we'll just cure aging by like being nice to people, right?
You gave a little teaser in the beginning about neuroimaging data.
Oh.
Can you share any of that?
So this is really, I don't think James is on the call, so we've been okay, in Achieve, I'll tell you, so, at baseline, we got baseline structural MRIs on a half sample. So roughly about 450 out of 977 had a baseline MRI. 3 years later, we were able to capture 300 of the 450. There was a lot of people only got 300. Some people obviously died. More importantly, when we restarted 3-year visits, there was already a gap in terms of some people who missed their 3, so now it's 3.5 year, and then the MRI scan, this is end of last year, beginning of last year, MRI scanners were backed up through the wazoo. So we only kept 300 back out of 450. It would have been a lot higher if it wasn't for COVID, but that's what we have 300 of the 450. So if you want to see, so then our original a priori analysis was to look at cortical thickness, right, which is a little more, it's probably a little more robust than looking at volumes. And then this is all predicated, if you look at the literature going back years now, we published papers here too as well, if you look at hearing loss and structural MRI, you see hearing loss in relatively a dose-dependent way being associated with accelerated atrophy, particularly with the lateral temporal lobe, but also in whole brain volume as well. And this is after observation and controlling for a bunch of stuff, and the thought is, well, it could be altered deprivation, we don't really know, but you clearly see hearing loss being linked with increased brain atrophy. So obviously corollary here, you could hear intervention, you reduce brain volume declines, all right, but not driven any a priori hypothesis beyond that, just saying, we'll see what we get. So this is actually interesting, I'll show you. All right, so this is brain MRI. So this is a total N of 445 at baseline, 3 years later, 300 roughly to 445. And this is with imputation, right? You can take an imputation, get the same result actually. So frontal lobe, temporal lobe, occipital lobe, parietal lobe, whole brain, this is average cortical thickness, right? So the results sort of speak for themselves. It's really interesting. So this is not just for Bonferroni or anything like that. This is just, we consider this purely exploratory observational work at this point. But, you know, MRI data is about as non-squishy as you get. I mean, there is nothing subjective about the MRI data. These were done by Cliff Jack's group. This is just 3 years, and we're seeing potentially some type of effect of hearing intervention on reducing cortical thickness declines. It sort of is. Well, honestly, I think Joe and I said we never expect to see anything here. The fact we're seeing something here is actually pretty interesting, right? So, you know, you think the only systematic bias could be here is something like the hearing image participants are following up or a lot more than the controls, but you're actually not seeing that at all. The covariates at baseline look to be fairly balanced. The rates of follow-up for 3 MRI scans are about the same. These are all adjusted analyses. They're adjusting for any covariate baseline differences too. And we're seeing, well, you see what you see, right? I don't have explanation for this. I really don't. You know, if anything, a priori, if I really think a priori had, you think maybe a priori said that maybe more the temporal lobe If anything, it's less in trouble with other domains. But this gets into the very interesting philosophically, right? We see hearing loss being associated with brain volume atrophy, particularly the loud temporal lobe, and you can make mechanism hypotheses there about how you have auditory deprivation and blah, 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 right? And then if you look at the hearing intervention, is not the same thing as reversing hearing loss. Hearing intervention, if it's mainly through a path essentially of driving social engagement, overall activity, is that maybe one reason why you're seeing maybe effects across all lobes, the whole global brain volume, global brain thickness? I don't know. So this is, I would say this is early. This is the early now, actually, I think it's that early. This is already fully adjusted, mixed models with imputation of missing data, right? So if you do if you do a complete case analysis, you see the same result. So this is actually pretty far along, I should get back. We're looking right now within each lobe. Again, it's going to be purely considered as an exploratory paper, not Bonferroni corrected for p-values. The p-values are purely for descriptive purpose. I think concepts are more interesting. And then within the brain lobes and things like that, you are seeing greater effects in the cingulate. I don't know why. But again, I was sort of all at this point now, just honestly very, very exploratory work right now. They hopefully guide further hypotheses. But it is really interesting to see that this is just 3 years, right? With a hearing intervention, and again, MRI data I would consider non-squishy. I mean, I should say cognitive squishy, but cognitive a little squishy, right? I mean, this is essentially structural MRI data. So
Now, at this point,
yeah,
we don't have a long-term MRI.
we do, Joe Koresh.
How many more years?
Up to 6. So
We
everyone's
wrote it into the thing.
Oh, stuck that one in, Joe. So yeah, the Brain Health Bob grant, which funds everyone for another minimally 3 years, it's getting MRI scans on everybody. So we'll see. Yeah, but yeah, it's encouraging, exciting, intriguing, all at the same time. Yeah. So yeah.
Did you do a sub-analysis in this group too, like
Go.
Eric versus?
We tried, but the problem is then when you start splitting it, Eric at this point then is only like 45 people or 40 people. So it's really hard to interpret. I mean, just you can't really do the analysis of 45 people.
I expect there would be a more yeah.
On the 40 people, you don't see any difference, but it's 40 people, so it's hard to interpret. So this is all combined analyses. We tried stratifying, but just the numbers are too small. Eric really justify stratifying at that point. Yeah,
It's interesting that you see, so obviously you have a lot of de novo and that you see in the de novo and you don't see just anything. So, but you maybe see a starting structural and maybe the trickle downstream effect in cognition, it takes time.
Yeah, exactly.
So,
yeah, if you sort of view cognitive decline as sort of a multi-hit sort of thing, which it really is, multiple different hits that allow to it. We may be capturing or arresting one hit that may trickle down to longer term effects, but yeah, but we're excited about this. I mean, honestly, I think Joe and I were joking. We didn't expect to get anything. We got this brain MRI scan funded on another premise of something else, but we stuck it in there. But the aim 3 of that grant, which is not to look at brain volumes with hearing intervention, we sort of stuck it in there. We always want to do it. So go figure. Yeah. So what we're so refining models a little more, but they're actually not much more refined. These are basically probably much final models. Only thing really left to do is again looking at within frontal lobe temporal, we can look at each regional structure now. But again, that would probably be a massive table like this, just showing just general trends. And then longer term, what Joe and I are working on now is trying to get the raw MRI data from Mayo here, because then we can work with Brian Casper, start doing voxel-based morphometry and other data analyses, look at a little more closely. So that's probably the next step. But I think for this paper, will probably just be cortical thickness. And then we also have ROI analyses too, region of interest analyses. Generally the same direction as well, not as robust as this, same direction though, but ROI analyses are hard because you have to adjust for brain volume size and things like that. So it's not as precise, I would say, as cortical thickness. Yeah.
What are the units? Is that a lot?
Millimeters. Straight millimeters. So these are like, in control subjects over 3 years, their cortical thickness on average declined by 0.01 millimeters, right? These are small effects. These are relatively small volume. It's only 3 years, don't forget, right? So these are directly in millimeters here. There's actually effect size there. So Cohen's the effect size. These are small effect size, 0.1 effect size. These are not big. That's also only for 3 years. In fact, you're even seeing anything after 3 years is sort of actually surprising to me, actually. You wouldn't think it 3 years would be enough, but maybe it is. Yeah. So the 6-year results would be more interesting. Yeah, and any type of study looking at hearing loss and brain MRI volume changes has usually been minimally over 7 to 20 years of follow-up. So 3 years here is showing a potential trend toward intervention, reducing volumetric report for declines is pretty crazy, actually. We'll see what the scientific review of this paper is.
Yeah, I mean, you'd wonder whether functional MRI could help, but community size sample this big, not so easy to do.
Yeah, but that's a study we're doing at Columbia though.
Oh, you're doing it, yeah.
Yeah, good. Yeah, so that's.
And what are the functional tasks?
And so it's resting states, I think it's only resting state, actually. I don't think we're doing task. No, there is task activity. It's resting state and also there's an auditory task too. Yeah, so that'll be interesting. I mean, I don't know if you guys heard though, at Columbia now, it's really sad. There was a death actually at the New York Psychiatric Institute. So all protocols are now shut down at Columbia. I think they're coming back online now. So, with Jonathan Gall, my colleague there who's running the study, they've had to stop the study early on and we'll get it restarted again.
Is this control for depression? Does depression track with hearing impairment?
Two thoughts, and it's not just for depression. They could adjust for the same covariates as before. So basically, level of hearing, sight, age, sex, and a few other things, right? Not depressing, potentially. In terms of, actually, are you asking about depression tracking?
Just
MRI?
curious, if depression tracks with hearing loss.
Oh, yeah. So there is a literature showing depressive symptomatology being associated with hearing loss and risk of depression, things like that. Al's actually done some initial analyses of looking at hearing intervention and depression, and it trends toward a protective effect. It actually doesn't meet significance, but again, trends in the right direction. Yeah.
Yeah, I mean,
there's very low levels of depression in the sample overall, like over time. But it looks like it's in the suggested direction, but this doesn't make such so we're still doing.
All right, folks, 5 p.m.
Yeah, thank you.
Thanks, Carl.